For single tooth it is very easy. Okay. The last premolar you have to give safety distance and drill.
Now buccolingually edutanu center point.
Center point and mesodensely also it is a center point. So you are taking your drill and keeping it here. Buccolingually in the center, mesodistally in the center. That is the insertion point. Insertion point. Insertion point is based on two things, buccolingual and mesodistal. And second point is angle. In what angle you have to go. You may start correctly. Correct point, mesodistally correct point. But if the drill goes like this, or if the drill goes like this, okay, buccolingually if the drill goes like this, if the goes like this, you should go in a proper correct center. So one is insertion point. Second is what is the angle now? What angle? Okay. So the angle is mesodistally what angle? Are you going for this? Yesterday we planned intentionally distal because the bone was very much soft. We wanted to get the mylohyoid engagement. So intentionally we slanted. So what mesodistally what angle you are planning? Mesodistally what angle you are planning? Most of the time it will be straight. Okay. Sometimes to avoid some nerve structures or to get some good bone, we may tilt mesodistally. Then buccolingually, what is the angle? If you want to get lingual cortical, you have to go slightly lingual. For lower anterior, you will be maintaining in the center between the buccal and lingual walls. You are not going to go anything. So what is the angulation? Mesodistally, buccolingually. Okay. So first thing, insertion point. Second thing is angulation. So then you start drill, maintaining these points. But actually, practically, how we do implant? No, this is the handpiece, this is the drill. The moment we take the handpiece, we retract. Already our foot will be in the pedal, partially pressing. We do it, then it will go mistakes. So the main trick is don't keep your foot on the pedal. First keep the drill, check all these things first. Mesodistally, I mean starting point, insertion point, is it correct? Mesodistally, buccolingually. Then is my angle is correct? Because you cannot redo it one time. The pilot drill goes correct, then the parallel drill, the other drills follow the same path blindly. Okay. The pilot drilling, the implantology is over. The correct pilot drill, implantology is over. Okay, the key step in implantology. Okay. Whatever you do planning, you are executing in the pilot drill stage. So more than drilling, before you start the drilling, you are using your eyes and finger to follow these principles. So during drilling also, you should not change the plan. You may be thinking, I have to go like this. Okay. But what is happening is, so this is the wrist. We do like this mistake when we do drilling. So if you do drilling, we will start correctly, but drill will go like this. Many implant X-rays in the beginning stage of doctors, if you see, the implant will be close to the premolar. Even some of our X-rays, if you see the olden X-rays, that is because this wrist is rotating. So this wrist should be locked. This point Dr. Muniratnam Naidu sir told. Okay. So lock the wrist and go straight. Do not allow this to move. Even in extraction, this wrist should be locked as much as possible. Otherwise, you will get a wrist pain. And not only that, when the wrist moves, we are inducing errors here. So diameter should always be above 4. The length is determined by the nerve structure. Okay. See, in all areas, the length can be determined by feel. In anterior, you will feel the drop. sinus area, you will feel the sinus drop. Even in pterygoid, you will feel the resistance, then drop. Okay. In lower anterior, you will feel the resistance of the lower cortical plane. In southern area also, you will feel the resistance of the myloid ridge. But the only area where you won't feel anything is the molar area. So you cannot decide the length on the spot. You have to decide the length before itself. This is the only area where the length.
6 area.
6 area.
Both upper and lower.
No, lower.
Lower alone because
Lower. Because there is no C2 here. We are not going to catch any C2. All other areas, some reference point is there. Only in the 6 area, there is no stopping point. You go, the nerve will come. Okay. So select the length before itself by measuring from panoramic or IOP or whatever it is. Of course, if you measure in the panoramic X-ray, there are some errors. You have to reduce the magnification errors. RVG is better. It is close to original. And select a 1 or 2 mm less. Nothing wrong in it. Our general rule is most of them we won't go more than 11.5 or 12. Most of them it will be only 10. The ridge is resolved, we resort to 8. That's it.
Mostly 8 to 10.
10. Very rarely, yesterday no, we placed 16. Because we tilted and we went till the lingual cortical.
two implants place பண்ணாலும் mostly in this.
Yes.
Yes.
So single implant, the doubt is clear, no? So when the means